Good evening, good afternoon, good morning, wherever you are in the world. My name is Jeff Kay. I'm the Vice President for Resource Development at Ben-Gurion University. I'm delighted to welcome you to the last meeting of our Ben-Gurion Circle webinar series for the moment, at least before Pesach, before Passover, where we have been welcoming back to BGU some of our incredible recipients of our undoc degrees over the years. Tonight is a real treat, and we're going to be dealing with a topic that absolutely every single one of you have been thinking about, talking about, reading about for the last year. And we've brought together two of the leading experts to have this conversation. What we're going to be doing, we're following the same pattern from previous meetings. I'll be introducing both our guest speaker and our interviewer, who's a local, and you'll know about him, of course, beforehand. And then they're going to have a dialogue for about 45 minutes. During that time, you can already, using the Q&A function, ask questions, and then to about 10 minutes or 15 minutes before the end, we'll stop, we'll pose some questions together, and we'll have a really great time for an evening. Nadav, just change your name because you're appearing as D. Lahav, and everybody knows that you're not a D. Lahav. But if not, what you will do. Anyway, so welcome everybody. It is really my pleasure to welcome you all, and particularly to welcome Professor Harvey Fineberg back to BGU. Although he's not physically in Beersheba at the moment, but he was there in 2016 when he received his undoc for the university. Just a few words about him. He's currently the president of the Gordon Betty Moore Foundation. He previously served as the president of the U.S. Institute of Medicine, as provost of Harvard University, as dean of the Harvard Chan School of Public Health. He's devoted most of his academic career to the fields of health policy and medical decision-making. His past research has focused on global health, assessment of medical technology, evaluation, and the use of vaccines, are very topical, and the dissemination of medical innovations. Professor Fineberg is the author of the books Clinical Decision Analysis, Innovators in Physician Education, and here's one that I like, An Epidemic That Never Was, and now an analysis of the controversial US immunization program against swine flu in 1976. He's co-edited books on such diverse topics as AIDS, prevention, vaccine safety, understanding risk in society and global health, and has authored numerous articles published in professional journals. Dr. Fineberg is the recipient of several honorary degrees, one of them ours, of course, the Frank A. Calderon Prize in Public Health, the Henry G. Friesen International Prize in Health Research, and the Harvard Medal awarded by the Alumni Association of the university, from which he earned both his bachelor's and his doctoral degrees. So, Professor Fineberg, thank you very much for being with us. Welcome back to BGU. And we brought you a treat to interview you tonight, because the best only deserves the best. And in front of us is a guest, but not really a guest. I think most of our audience knows Professor Nadav Davidovitch very well. He's no longer a D Lahav on his screen, which is pretty good. Professor Nadav Davidovitch, MD, MPH, PhD, is an epidemiologist and public health physician. He's a full professor and director of the School of Public Health, Faculty of Health Sciences of Ben-Gurion University of the Negev. His main research interests include health policy, public health, the Israeli healthcare system, public health ethics, and global health. Three of his 4 degrees are from Tel Aviv University, which is pretty good, but then he came to BGU and he got his Master's in Public Health, and that, so he really reached the pinnacle. But what I want to tell you, Professor Fineberg, is Nadav, if you don't mind me calling him Nadav, is the closest thing that we have to Dr. Fauci. I think he's a lot better looking than Dr. Fauci, but certainly he has been our Dr. Fauci of the last year. And for the older members of the audience, of which I am one, people who were in Israel in 1991 during the first Gulf War, Israelis will remember that after we were getting attacked by missiles from Iraq and Saddam Hussein, stuff like that, we had somebody who was known as the person who would calm us all down. And that was actually a man called Nachman Shai, who was the IDF spokesman at the time. And he would come on our TV at the time and tell us to drink water and calm down. And he would give us perspective. if anything, Professor Nadav Davidovitch has become Israel's Nachman Shai of this last period of time. He is the calm, understanding voice that has been on every single Israeli TV station and radio for the last year, and we're proud to say he's one of ours. He belongs to BGU. So without further ado, I hand it over to you, Nadav, Professor Nadav Davidovitch, to interview Professor Harvey Fineberg. Thank you very much for being with us.
Wow, thank you so much, Jeff. This was very kind of you. And I must say that I'm so honored, and you know, there is a phrase on Rosh Hashanah when the cantor is saying that, you know, I'm now humbled to be like, you know, hineni ani mimas. So Professor Harvey Fineberg, of course, is one of the heroes of public health. And several years ago, we were also honored to have him to receive the honorary degree, and also to give several lectures, one also in our class on health policy. And in some ways, Professor Fineberg, I want to return to this lecture because it was about the paradox of prevention. And as a public health physician, I'm using your insights many times, and I think that it's one of the most important questions and reflections, internal reflections about on a profession. And you know, the title of our conversation tonight and for your morning or afternoon, early afternoon, is the paradox of prevention in the age of COVID-19. Now, you know, many people are talking about the COVIDization of science, and you know, we need to have the perspective. But I think that you would agree that COVID, in many ways, it's a kind of a mirror in front of us that maybe can make us reflect on maybe future challenges such as climate change, migration and health inequalities. So, but before we get to the paradox of prevention, you know, I'd really like you to tell us a bit how you got into public health. For example, I wanted to be a pediatrician, and I have a father who is an anesthesiologist, a mother an ICU nurse. So I was sure that I don't want to go there. And then I served, since I served in the military, I was lucky to meet Professor Itamar Grotto and some other friends, Professor Michael Hartal, and they got me into public health, and I never, you know, turned away from that. I did my clinical year of the residency in pediatrics in Oka, and I think it was the best decision of my life. But I really like, maybe if you can tell us how you got into public health, and what is public health for you? What is the passion?
Yeah, Nadav, thank you so very much for your excellent question. I do want to just also thank Jeff for his beautiful introduction for both of us, and to say what a pleasure it is to be with you on this occasion and to have a chance to converse about public health, about COVID, about the implications for health, for the way that we deal with so many of our challenges as you're describing. For me personally, I was really not sure when I began my undergraduate university training what I would do in life, what kind of field I would follow. And I got very excited by biology. And I decided, because I was also interested in people, that medicine would be a good field for me to pursue. So I applied to medical school, but I was always interested in also the social dimensions of medical care and medical practice. And at that time at Harvard, where I was a student, there was just starting up a new program in public policy. And it was inviting individuals with background in medicine or law or even business and others to come and study public policy. So I entered in the first class. And in the meantime was balancing public policy with medical training. I was a first-year resident at a hospital in Boston called the Beth Israel Hospital. And the Beth Israel at that time, now it's the Beth Israel Deaconess, but at that time, the Beth Israel Hospital was led in the Department of Medicine by a man named Howard Hyatt. Just before I came to the hospital, after he had recruited and selected the incoming group, he decided to become the dean of the Harvard School of Public Health, as it was then called. So he called me and he said to me, you know, you're interested in medicine and public policy. Public health is the perfect vector to bring those two together. You should really come join us after this year at the school. We're building a fantastic new vision of public health. It's going to be grounded in science more than ever. It's going to use data. It's going to include analytics like you have studied in public policy, a bigger emphasis on management, on economics, on all the things that go into effective decision-making. He got me very excited. And so I followed him to the school, then as a junior professor, and came to appreciate the subtlety and importance of the core fields that make up public health. And what attracted me, Nadav, to this field was the idea that you could do things that would affect millions of lives at a time. Whereas in medicine, you were doing very important, but still one patient at a time intervention. And the capacity for amplification, for profound difference in people's lives, that was what brought me to the field.
Wow, I guess that I totally agree. The idea that you can work with communities, with populations, I think it's something that is really amazing. I would say that some people sometimes they feel that this might be problematic. You know, you need to deal with politics. You need to deal with lots of institutions, people that are outside the normal, you know, medical care world. Now, I find it exciting. I think that also during COVID-19 right now, when I'm rethinking about, you know, last year, what happened in Israel, in the world, also in the Negev, I see lots of opportunities working with communities, for example, on compliance to vaccinations among the Bedouin community, working with mayors, with rabbis, with religious leaders. I found it fascinating. I know that some people, maybe they don't have, you know, the patience, you know, to do this thing. And I think it also reflected in how we need to raise the new generation of public health practitioners. We are now entering Ben-Gurion University together with other institutions. We won an Erasmus capacity building with the European Union, and we'll be working on leadership. I don't think that, at least in Israel, we were working enough on the question of leadership and social responsibility. Many times it was too much, you know, about epidemiology, that of course it's, you know, the queen of public health. And I wonder how you see, you know, the part of politics or leadership, or how you think this should be part of maybe also medical education, not just public health education. And maybe you can tell us some examples from your deanship at Harvard.
Nadav, you know, your characterization of the multiplicity of relevant disciplines is so germane to public health. In its essence, public health is what I describe as a problem-grounded field. It is defined according to the health needs that you are trying to meet. It's not a discipline-defined field. Rather, it takes advantage of relevant disciplines, whatever they may be, that can be brought to bear to solve the problem of health, preservation of health, prevention of disease, promotion of health, the core problem that we are trying to meet and resolve in public health. So that means it's a very eclectic field when it comes to relevant disciplines. It means, yes, political analysis becomes relevant. Yes, the queen science of public health epidemiology is grounded on everything because you have to know how disease expresses itself, where it originates, how it manifests in the population, how it spreads, and so forth, all basic epidemiology. It means you have to also turn to the natural sciences. You have to understand the genomic origin. You have to utilize all of the tools in the social sciences to understand the behavioral determinants. So public health, to be successful, is a field that by its nature must bring together the best expertise that can be brought to bear in a relevant way on solving and meeting the health needs of a population. This brings us to the question of leadership that you described. Because in public health, yes, you have disciplinary expertise. You should bring forward people with distinctive expertise, whether it's environmental health or industrial hygiene or epidemiology or behavioral science and health. Any of those fields can be relevant expertise. But what is leadership in such a field? And leadership has to express itself in the field of practice, whether in government or non-government, whether in industry or in the community. It has to express itself in the academy, in the university, in the ground where we prepare future leaders. And this question of what does it take to prepare and nurture a leader in public health when it has to be able to take advantage of these multiple disciplines, when there needs to be a core grounding in the values. This has been the ongoing challenge for schools of public health since they began more than 100 years ago. I would say that public health leadership requires values and commitment to the health of populations. It requires a core of knowledge about the determinants and causes of ill health and the ways one can prevent and reverse ill health. It requires an appreciation of the role of the multiple disciplines, not expertise in every discipline, it's impossible, but an appreciation of why it matters and how it can be brought to bear. And then on top of that, all of the basic qualities that you need as a leader in any field, the qualities of vision, the qualities of communication, the qualities of integrity, and so on. All of this then comes to bear. And, you know, when we put it all together, we get Nadav Davidovitch. So there we are.
Wow. You know, you said one of the most important words, and this is how, because I think that the what is now much better understood. You know, the question of the social determinants of health and the issues of health inequities. You know, things from urban planning, you know, to advising for quality indicators, etc., etc. And it seems that the current challenge is mainly about how to do it, because, you know, for so many, even, you know, just taking the definition of the World Health Organization, that health is not just absence of disease, but it's also about, you know, the complete was a bit naive then, but let's leave it aside for now. The question of well-being as something that is both physical, mental, and social. And it took several decades for the World Health Organization to understand, this whole idea, for example, of health in all policies. And unfortunately, still in many places, we are failing. We need to tell the truth. And this is bringing me to the question of the paradox of prevention, because there's so many papers written about the importance of prevention that is, even in terms of being much more cost effective, of course, in its values of, reducing inequalities, etc. And I'm citing here from your famous article, what are the reasons why prevention is so difficult? So success is invisible, the lack of drama. It's much more dramatic, to show after an earthquake, a physician doing some very sophisticated surgery. Statistics that many times have a little emotional effect, the delay before rewards appear, benefits often do not accrue to the payer, and we need a persistent behavior change, different biases, and all other things that you raise, including, by the way, the commercial interests that you bravely, I need to say, discuss, because, when you're bringing in this kind of criticism, there are very powerful forces that are not so happy. So I wonder if you can tell us a bit more about your experience, again, about how to translate all of the amazing knowledge that accumulated, in social epidemiology, in all these different disciplines that you raised, and how you can answer actually these paradoxes, and maybe if you have some lessons from COVID-19.
Yeah, this is something that I have thought a lot about, because most of the time when we are working in public health, we are working in the shadow. We are working in the background. We're working on the infrastructure. We're working on conditions that have all those properties you described. They're not visible, they're not dramatic, they don't invite us to get emotionally involved. All of that is true most of the time in public health in terms of our success. Our success when when nothing happens. How many people did not have the heart attack? Can you raise your hand if you did not have the heart attack because you stopped smoking, or you changed your diet, or you took your statin, or whatever reason? Raise your hand if that's why. None of us knows. We don't know for sure. So we can look at it statistically. And by the way, I like to say every health statistic is a number with a tier attached to it. There is a human life involved in every one of these numbers. And how to convey that, how to make it more real to people most of the time is a very big challenge. In general, I would say, Nadav, that most of us trained in the sciences or in public health are disciplined to think about evidence in terms of studies, experiments, trials, the things that really produce quantitative, evaluable data that can tell us what is or is not more likely true in the world. And many of us who are scientifically minded really shun individual stories. We know an anecdote doesn't amount to anything. In fact, we could say the plural of anecdote is not evidence. So we are conditioned to look in the science for evidence. Now, this is the key point, getting back to how you communicate. I believe that for those of us in public health, in the sciences, who want to reach people to understand the core message, we have to be able to utilize the personal story, the individual anecdote, the episode that everyone relates to, but to frame it with the knowledge of what the science teaches. So the trick, I think, is to remain faithful to the lesson of the science and the evidence, but as a communicator, to use the tools that most effectively reach individual people. And those include the personal stories. That's why every news article that will start about a COVID story, an immunization story, or a hospital story, it will always begin with Mrs. G arrived at the hospital at 6:38 p.m. It brings you into the story. So that's what I think we need to learn as professionals and communicators in the field of public health. You asked about COVID, how COVID has affected and changed. First, COVID has put an added premium on clear, consistent, effective, candid, accurate, and repeated communication. This is real time. These are choices people are making that are life and death in everyday life. Communication is more important than ever. Interestingly, when a COVID occurs, that is a visible pandemic, it actually overcomes many of those paradoxes that I wrote about, because it's no longer invisible. It's no longer in the background. It's in the foreground. It's what we are now worried about. And it is, in a way, the time and opportunity for public health to shine. One last point that you also alluded to. The COVID pandemic, the COVID experience, has not only been the severe problem of health and the economy in its own right, but it has exposed and exacerbated many other background problems, including the problems of disadvantaged populations, of inequities, of the judgment of resource allocation, of governmental aptitude or ineptness. All of these things are elevated into more sharp relief because of the urgency and importance of the COVID pandemic.
Thank you so much. This was so powerful. I think that the personal anecdote is maybe returning us to, being humane, returning to the very humane interaction. And it's also about the question, what is public health? And unfortunately, I saw many times in Israel and abroad that there are both experts, but the public, sometimes public health is something about let's protect us from them. And I think it's so important to remember that finally, to view someone, this person is not a carrier of a disease, or even sometimes, unfortunately, be seen as the disease itself, as we saw so many times throughout history, in different diseases, and unfortunately also in the Jewish history, history of migration. When you see in front of you, first of all, a human being, this is something so different. And also when communities understand that you're really interested in them. So I think it's about bringing back, the humane part and also trust. Now, we did in Israel several studies about trust, and I'm also leading a working group for the National Institute for Health Policy research about trust. And what was so sad sometimes that we had what is called circular mistrust. So it's about the public maybe not trusting the government or experts. Again, it's of course more complicated, different layers. But sometimes you see that the government maybe is not trusting enough the public. And sometimes you see that we entered into lockdowns or some really measures that you can find really no epidemiological evidence, like limiting people from going more than 1,000 meters, because the government stopped to trust the public. Now, I think that with vaccinations in a strange, not strange, but maybe in a unique way, we saw maybe regaining trust when you turn vaccination not into a personal decision, but something that is more related to the community. And especially now that we know from the data being gathered in Israel, we are very proud. Israel is not a laboratory. We're doing post-marketing surveillance, it's phase 4. We are not guinea pig, but we are proud to give the data. We're also very proud that one of the most important articles on New England Journal of Medicine, published with researchers both from our School of Public Health, Harvard School of Public Health, University of Michigan, just maybe 2 weeks ago, about the Clalit Health Services study with 600,000 people versus matched controls. But we saw now with vaccines that it's not just protecting me, it's protecting others. And lots of bottom-up initiatives that I think that we can maybe take them, and in a way I want to relate to what you said, and bringing back the community, bringing back the personal stories. Because I think that without trust, it's almost impossible to have any public health interventions. Now, I'm very happy that in the US now we see, again, I think more trust now in experts. I think that, you know, the role of the CDC, the role of public health experts now becoming maybe a different place. Also the US that got back to the World Health Organization. I think that all of this is part of the question of trust. And this time I'm talking about the global trust and the solidarity among countries. So I know it's a bit about politics, and I don't know how comfortable you feel about it, but can you tell us a bit about the role of experts now and the trust, how it was, you know, presented in the US? And of course, there are different states, right? So you have Massachusetts is not like Texas, not like Michigan or California or other places. So how you can reflect about the question of trust and bringing back this kind of humane experience?
Yeah, you know, trust is fundamental to success in communication, in public health. I really appreciate your point about bringing forward the humanity of health concern, which means individual lives, individual people, and genuinely caring. You know, the very basic point you begin with is, if you want to be trusted, you have to be trustworthy. So the first requirement is you have to know what you're talking about, you have to know what you don't know, and you have to be able to clearly and effectively communicate the difference. It is related to the question of the role of the scientist or expert in a matter as urgent as a COVID-19 pandemic. We had in the previous US administration under President Trump, what often was a stifled voice of science in presenting evidence. Of course, as you know, as well as anyone, Nadav, scientists legitimately can disagree. They can disagree about the evidence, they can disagree about the interpretation, they certainly can disagree about the implications for policy. So you want those debates. You don't want to artificially prevent any voice from being heard. But we had a situation in the United States where a neuroradiologist became one of the president's confidants on advice about public health. And with all due respect to the individual and to the importance of the field, it's just not the same as being an expert in epidemiology, infectious disease, and public health. Now, that means you have to know yourself, you have to know your own limits, you have to know your own abilities, and you have to be, as an expert in the field, prepared to be able to communicate and to hear others in that communication. Now, what does it mean to gain trust? Being truthful and being trustworthy, at least in your own mind, is not always the complete answer, because you have to begin not with the originator of the message, you have to begin with the audience. Who does the audience already trust? The audience will not trust a messenger because of the message. The audience will trust the message because of the messenger. So you begin with the question, who is already trusted in this community? Is it the religious leader? Is it the community civic leader? Is it an entertainer, a sports figure, a celebrity? Is it a political figure? Not as often, but could it be? Could it be a spokesperson who has gained the eminent respect because of past performance, who can now be brought to bear in the current situation? So the way to gain trust is in a way to take advantage of where the community's trust is already placed. And it's not necessarily the same messenger for every different community. You target your messenger and selection of messenger and framing of the message to the community you're trying to reach. That is really fundamental to success in public health.
This is so true. I can think of many different examples also here in Israel. I must say that we saw, unfortunately, many times, new arrivals from sometime physicists or other people that, again, it's great to work with them, but because of a certain vacuum, it's a long story. We are doing research, by the way, now about scientific advisory committees and their role. It's part of a international study. And many times it created also mistrust because of the variety of opinions. I'm very happy to say that now it's much more coordinated, and I totally agree that sometimes, of course, people disagree. The question is how you are handling all of that. And here now at Ben-Gurion University, we are developing quite a lot now, this whole notion of evidence-informed decision-making and implementation science. Together with Professor Moriah Allen from School of Public Health, we are developing an online course that will be taking place with international students this spring. And I think that your personal background, as you mentioned, coming from public policy is so crucial for developing a different vision, a much broader vision. On a personal note, I also need to say that I know that you are an excellent friend with Professor Joe Pliskin and Nava Pliskin, that I'm almost sure that are here with us. And actually they introduced me to you. And lots of relationship, of course, between our School of Public Health and Harvard University School of Public Health. I wonder if you could tell us maybe a bit more about your role in the Institute of Medicine, because this is another very important component of your career. And I think it's related to what we are discussing now, because I think that within the Institute of Medicine, many times you need to get into consensus. And part of trust is also creating consensus and also conveying and doing the translation to policymakers, translation to the public. So if you can tell us a bit about this part of your career.
And just let me interrupt you. And as you're about to answer, this is a time for people who are attendees, and we have a very large group, to start sending your questions in the Q&A function, and then we'll be able to present it to Professor Fineberg. So please.
Well, thank you, Nadav, also for that question. I would just say very briefly, I was president at the Institute of Medicine, now the National Academy of Medicine, for 2 6-year terms. And if I were to say what was the unifying theme of the term that I tried to bring, it was all about increasing the impact of what we do. It was all about making a difference in the world, not simply producing excellent reports that might sit on the shelf. In fact, when I began, I asked the staff to compile a list of the reports that they believed were technically the most sophisticated and excellent, and the list of reports they thought were the most impactful on changing policy. And I'm happy to say there was some overlap, but they were not identical. And my goal, in a way, over the 12 years was to make the overlap more complete. Now, I also served in the National Academies as the chair of a committee, of a number of committees, but one in particular that's relevant to us today is a committee on reproducibility and replicability in science, which was all about the question of evidence that we're discussing. And then most recently, for the last approximately 14 months, I've chaired a standing committee on emerging infectious disease and 21st century health threats, which is designed to be a resource for government officials, mainly in the Office of Science and Technology Policy with the White House and in the Department of Health and Human Services, to give expert advice as needed on questions that might come before those agencies, or where those agencies in turn would contribute to the larger policy discussion. I'm not sure uniformly how great the impact was, but I can think of a number of instances where I believe the work of that committee was helpful over the course of the past year. And the features of that work was that it not only had to be accurate, scientifically informed, but it had to be timely, because this work was under very tight relevance deadlines. So I feel that expert groups like a National Academy can be very valuable when they can manage not simply to do the visionary, long-term, stage-setting, field-building assessment, but tackle real-time, urgent, important problems that can inform decision makers today. Both tools, they're not mutually exclusive, both tools should be available to those of us who hope to make a difference for the health or for the well-being in a broader sense of our communities.
I'd like to ask a question, if I may, Professor Fineberg.
Please.
The aftermath. There'll be a day, hopefully it'll be sooner, when this is beyond us, we're over it. What will the state of public health be in your country and other countries? Is our society going to be more robust, more resilient, more prepared for the next time, or will we be more, will our wounds still be open for a long time? Will we be more vulnerable? How do you see society, public health-wise, once this is all over?
Jeff, I'd like to make a distinction in thinking about the future between things that we can control and things that are under human control. I was reminded the late Bernard Lown, just passed away at age 99 a few weeks ago, was a founder of the International Physicians for Prevention of Nuclear War, and representing them, received the Nobel Peace Prize one year. And he was asked, are you an optimist or are you a pessimist? And he said, I'm a pessimist about the past because I can't do anything to change it. But I am an optimist about the future because that's in our hands. And I feel the same way really with your question. If we in the field of public health, if leadership at every level in the community and in government can recognize the importance of lessons learned from the COVID, then we can achieve the positive side of your question. We can be better prepared for the next time. We can do more to reduce the likelihood of such a major catastrophe. We can put in place the conditions that will reduce the inequity which feeds this kind of differential burden whenever it strikes. So I would like to say it's up to us.
Right. Well, that's fair. So I'm going to, Nadav, can I take a couple of questions from the audience?
Yes, just before the questions, of course, Professor Fineberg, I totally agree. Just to say that we're also entering now the 6th year of doing courses on healthy placemaking. And this time we're doing, again, an online course, an international online course. And in many ways, it's about rethinking, you know, the space, urban planning, with lessons from COVID-19. It's both a bottom-up approach, but also we call it sometimes middle out, to take all the people that are, you know, in the middle. Sometimes we call them, and it's based on a former PhD of mine who is now the Director of Population Health at New Jersey Department of Health. It's called a bureaucrat activist. It sounds like an oxymoron, but the idea is to have people in the middle that many times they know how to break the walls and act, you know, in almost an activist way, also with the NGOs. And I totally agree that it's in our hands. So it's not deterministic. It's not, Jeff, that everything will be either worse or good or excellent. It's in our hand, and I think we got lots of lessons. And I personally much more preoccupied now with issues of climate change, for example, that I think it's much, you know, harder challenge. And I'm so happy that our president of BGU, Professor Dani Chaimovitz, and the rector, Professor Chaim Ames, they announced a new school on climate change and sustainability that will be above all faculties. And of course, the School of Public Health is also integrated. And you said, the Professor Fineberg, to public health about a problem kind of based approach. So climate change is, of course, one of them, and it has deep influences on everything, including public health. And again, it's in our own hands. So it's like we, you know, in soccer, you get like a yellow ticket. Yeah, so maybe it's a yellow ticket for us to rethink many future challenges.
I guess I'm going to ask a couple of questions that we've been sending, but I guess what the big unknown for me, and I think Professor Fineberg, you've said time will tell, is whether as a society, whether the collective is strengthened and we see community and we see our ability to affect each other positively and the dangers if we're not careful, or is it every man or every woman for themselves and we're off doing our own thing? I guess, you know, every society is going to be tested in one way or the other, and that's true of climate change as well. It's true of preservation and it's true of sustainability. So, but we'll wait for that. But I have a couple of questions from our audience. One about us and one about you. I'll start with the one about you. And the question is, what is the future of primary prevention, health promotion, and lifestyle medicine in the public health system in the US? So that's one. And the second question about us is, it's a kind of plug for us, which is good, which is BGU's School of Public Health is the newest and largest in Israel. How, in your opinion, can we make this important field more sought after and one that BGU is recognized as a leader in? So these two questions for you.
Okay, well, let me start. On the first question, what is the future for primary prevention, and particularly around behavior? You know, traditionally, it's often said that you can think about the origin of disease in terms of, and the outcomes in terms of genetic endowment, in terms of behavioral choices, in terms of environmental exposure, and in terms of medical care interventions that might be enacted. Those fundamentals will, in my opinion, continue for the foreseeable future. But what will change is the degree of refinement and individualization and density of relevant data that can inform the choices and changes that can enable any one individual to live healthier and longer. We are getting more and more data about us all the time. It's now being used mainly for commercial purposes, but imagine systems that gradually take advantage of that plethora of information in a real-time way and in a personally relevant way to help guide your choices and your life to make you more likely to live healthier and longer. So the future, as I see it, will be more individualized, more data intense, and more persuasive, therefore, in the relevance to me as an individual, to my family, what we need to do. Now, was the second question for Nadav or for me?
No, I think it's for you. I think it's Nadav would want to hear the answer as well.
Well, you know, I think I already was listening as Nadav was describing some of the global outreach and courses that really make the school have a global presence, not merely as important as it is an Israeli presence. I think a part of it is being, in a continuing way, welcoming to peoples from all over the world. Israel has certain natural advantages, not necessarily the endowment of the lands that have been too dry or too bereft of natural resource, but the people who have come to Israel from all over the world, who bring the mix of culture, the mix of language, the ability to connect anywhere, makes Israel a very natural locus for global crossroads, for education, in public health, frankly, and in other fields as well. So I think the building on the capacity of the people, the vision of what is needed for global advances in health, and enabling the school to play that role as a central educator, I think is a wonderfully opportune future for Ben-Gurion University's public health school.
Thank you. Nadav, would you like to have a finishing question before we release Professor Fineberg?
Well, no, first of all, wow, Professor Fineberg, thank you so much. So many insights, and it's always such an amazing pleasure to hear you. Now I even have the chance to, have it as a almost intimate conversation. Of course, many other people here. It's being recorded, but there's something interesting about this Zoom experience. I don't know. Sometimes it's really amazing. Of course, we're all missing the physical component. Maybe it's not a question, just to say that of course, we take your leadership in all the different stations that we follow, including in the School of Public Health, and what you mentioned about the Institute of Medicine and your work. So it's really something that we are teaching and taking into our hearts. Again, returning to the paradox of prevention. I think for the School of Public Health that indeed it's strange. It's the newest one, but already the largest, because we had all the components, but sometimes internal politics even in academia, there is internal politics, you know, Professor Fineberg. It took us some time, but we joined the Association of Schools of Public Health in the European region. ASFER, I'm now was voted to be on the board, and we have this process on capacity building that I think will be really great. So having the right balance between the science and the social responsibility and accountability, exactly in the ways that you presented, bringing humanism also, I think it's probably the right recipe. Maybe also some coffee, you know, to stay awake during the nights. And I also want to mention another person that was very important for me that I know that you know him very well. And this is Professor Alan Brandt. He was on my committee on my PhD. For those of you who don't know him, he was the Dean of the Faculty of Arts and Sciences at Harvard, and he's also on social medicine and schools of public health. And I'm mentioning him also because of his personal ethics and professionalism. And for those of you maybe not aware, you know, we spoke very briefly, we mentioned the issue of fighting the commercial interest. He was an expert, he gave an expert testimony against Philip Morris. And I know it was a very hard time for him, he was attacked. And I think that many times, you know, in public health, we are under pressure from different interests, and maybe it's another reason to create a community like we're doing here at Ben-Gurion University. I really want to take the opportunity to thank all the, you know, all the professors and the School of Public Health, all the administrative staff, the PhD students, the MPH, MHA, and all other. We have 5 different programs. In these hard times, you know, we continue to work together and also doing lots of things for the community, working to increase immunization rates, working with the elderly. And I think you agree, Professor Fineberg, that this is one of the amazing things in schools of public health, that we are very connected to the community. It's part of our mission. So it's not just, you know, being in the ivory tower, but practicing what we are preaching. And I think it's maybe part of the answer, Jeff, to the question about our mission. And it's part of the DNA of Ben-Gurion University, being excellent in science, but also having the big heart and the, you know, the sense of community and for the development of the Negev.
So thank you, Nadav. Thank you very much for being a wonderful interviewer. Professor Fineberg, you already know this, but when you accepted the UNDOC 5 years ago, you became part of the BGU family. As I understand, it's been 5 years since you've been back to visit us. So the last year will give you a discount because nobody was traveling. But I think it means that since you're part of the family, you have to come back and see us very, very soon. As Nadav mentioned, we have a wonderful new president, Professor Danny Chamovich, who I think you know, I know you know, in fact. And we would love to welcome you. And I think there's a tremendous amount that we can learn from you, from your experience and from your insights. And we want to thank you for staying with us, even 5 years after you got the UNDOC and giving us your time. I want to thank the audience for being with us. And I think it's not too early to wish everybody a very happy Passover, a very happy Pesach, and good holidays. I think filled with health and happiness, and that we can get together, our families, maybe do a little bit of hugging with both of your permission if we're allowed to, and a prayer and a hope that a year from now, this really is beyond us, and we're starting to look at some of the other challenges in our society. So from me, Jeff K, I want to thank both of you and all of our audience for being with us for a really fascinating evening, and wish you all the best.
Thank you so very much. It's been a great pleasure to be with you.
Thank you. Thank you so much.
Bye, everybody.